I'm Dr. Christopher Browne. I'd like to thank you all for coming out today, listening to me talk about hip or knee pain, and knee pain. Hopefully some of this information could be useful to you in your healthcare or a friend or a family member. Again, we're going to try to put this out online so other family members or people can see it. I recognize some of you from around town in my office, so nice to see you as well. And again, at the end, if you have any questions, I'll stay around as long as you want to try to answer any questions you might have. A little bit before we start about me, I think it's important anytime you listen to somebody lecture, you kind of question, why should I even be sitting in this chair listening to this guy? You know, why is he an expert? What qualifies him? So here's a little bit about me. I'm from Kansas originally. I got my undergraduate degree at Notre Dame. I came back home and did medical school at the University of Kansas. Then, like all orthopedists, I spent 5 years in orthopedic residency training. That's basically general training on hip and knee pain, but also ankle and shoulder and elbow and hand and bone and joint, you name it, we kind of did it. After 5 years, then you can go out and work, but I didn't do that like most orthopedists. I then went back and was accepted into and completed a total joint fellowship in California. It was basically there where I spent a year training with an expert in hip and knee replacement or hip and knee pain. So I spent a year studying it, evaluating it, doing hundreds of hip and knee replacements. Then I got my job here in Tulsa in 2001. I've been here ever since. I'm a partner at Eastern Oklahoma Orthopedic. My specialty is, I guess, hip and knee pain. My expertise is joint replacement. So I've been there 13 years, done over 4,000, it's probably getting closer to 5,000 hip and knee replacements during that time. I probably do 500 or 600 a year, depending on what comes in, so to speak. So I tell patients, I may not be an expert, but I've got a lot of experience in dealing with the problem. So the things I'm going to touch on today are kind of understanding hip and knee pain, give you a good idea why you hurt, the treatment options, various ones, not just surgical, what a joint replacement surgery involves. I think a lot of people coming in with various ideas they've been told by friends of what the joint replacement means, realistic expectations about your joint replacement, and then I'll touch on some of the, I guess, more recent things that have come about like robotics and pain care afterwards. To understand what causes knee pain, I think it's good to have a basic understanding of what do you mean by a knee or a hip. And you know, it's my job as a doctor to try to explain things even in the office or here in simple enough terms you have a really kind of an idea of why I want to do something and why what I'm going to do is going to help you. And this is one way of kind of going about it. So the knee is actually made of 3 bones. It's made of the distal femur bone, the proximal shin bone or the tibia, and then the kneecap. Those bones are connected by tissues called ligaments, keep them together. They move because muscles and tendons move it. The knee is actually a hinge joint. It moves back and forth. It doesn't move side to side. It doesn't go around. It moves like a door hinge, back and forth. Okay? The knee joint has specialized unique tissue on the inside like most joints. It has cartilage. Okay? Now there's 2 types of cartilage in the knee. There's the cartilage that's on the end of the bone, okay, and it's actually on the end of the femur and the top of the tibia and the backside of the kneecap. That's hyaline cartilage. It's very unique. It coats the surface. We talk about it being very smooth. Its coefficient of friction, its smoothness, is more smooth than 2 ice cubes rubbed together. So it's very smooth when the joint glides over itself. It's also extremely durable. It's only 8 millimeters thick, but it's basically built for a lifetime of walking and jogging and jumping and things like that. So it's very, very durable as well. I mean, it may last 30, 40, 50 years, may last your whole life. And there's nothing we create that's that good, all right? It's also unique for an unfortunate reason. It's the only cartilage you're ever gonna get, all right? So what you're born with is what you got. You can't grow cartilage. Cartilage doesn't heal itself. I can't inject anything into the joint that makes new cartilage. So when you talk about joint pain, especially in the knee, what are some causes? Well, it can be injury to those cartilage tissues, okay? So it can be injury to that cartilage or coating, such as wear of that cartilage cap, all right? So you can think of it in terms of like the tread on a tire. You can think of the tread on a tire when you get out of a brand new tire, put it on the car, it has a nice new tread, but over time that tread gradually wears away. We can think of that coating on the surface of the bone wearing away as well, okay? And you can think of very mild wear or greater wear to the point that it's worn completely away and the bone is poking through. What's a more general term for that? It's arthritis. So arthritis is just wearing away of the cartilage, okay? And what can that cause? Well, that can cause pain. It can cause pain because of mechanical pain from the actual fact that it's gone, rubbing bone on bone, which pushes stress on the bone. It can also cause pain because it causes inflammation and swelling. And that's oftentimes the pain you have after you get off your feet and it still hurts. It still aches and is sore, inflammation. Now there's other types of, again, there's another type of cartilage in the joint. There's a cartilage on the inside and the outside of the joint called meniscus cartilage. That cartilage sits on top of the shin bone. It also serves as a purpose. It deals with compression in the joint. It also serves to stabilize the joint, okay? And it's very durable as well. But much like the other cartilage, it can be injured as well. And when you think of tears of the cartilage, that's the most common thing we think of as tears of the meniscus. You often hear of athletes tearing their cartilage, okay? The meniscus itself doesn't have nerve fibers, so when you tear it, it doesn't hurt to tear, but it's kind of like having a hangnail on the end of your finger. It's attached to the outside of the joint, so when it gets pulled on, much like you pull a hangnail, it hurts. And it can cause pain from that mechanical pulling. And it can also make the joint swell because it's irritated. Now, the meniscus tissue, much like the other cartilage, doesn't heal itself. Once it's torn, it's torn. And actually, it's more commonly torn in older population. Why? It's kind of like a piece of rubber. If you ever buy a piece of rubber at the store and then you set it out in the sun for 4 or 5 years and you come back to that piece of rubber, that nice flexible piece of rubber is now turned into a big brittle thing. That's kind of what happens to cartilage over time. It gets more brittle. So actually, you're more prone to cartilage injury as you get older. So those are a couple reasons why your knee might hurt. Well, how about the hip joint? What's the hip joint made of? Well, the hip joint's made of 2 bones as well. The top part of the femur bone and the outside portion of the pelvis, or a socket. They have ligaments that attach them to each other and hold them close. They have muscles and tendons that move them. And the joint really is kind of a ball and socket joint. It's a ball, top part of the femur, and a socket it fits into. So that joint has more freedom of movement. It goes back and forth and side to side and around and around. Much like the knee, it has 2 types of cartilage. It has a cartilage on the top that's very, smooth. That cartilage cap, it's both inside the cup and on the ball. Makes that joint move very smoothly. It's very compressible and durable. There's also a cartilage that surrounds the periphery of that joint. You won't be able to see it here, but it surrounds the outside. It's called the labrum. It's hard to explain. It's kind of like if you had a basketball hoop that you could shoot baskets into, and you were able to make a funnel on top of that, so when you shot a ball, if you're not right in, it would kind of catch the ball and make it go into the hoop. The labrum's kind of like that. It's a tissue that extends outward. It allows your hip to have more mobility, so to speak. That sits on the outside. It's very durable as well, but unfortunately both these tissues also are the only tissue you're ever going to get. Once it's injured, it's injured. Once it's gone, it's gone. So what could cause hip pain? Well, you can have hip pain from injury to either one or both. That labrum can be torn. It's not uncommon in young people, sports injuries, gymnastics, to tear the labrum. Can cause pain and swelling. Doesn't heal itself. Or you can more commonly injure that cartilage cap or wear it away. Again, arthritis of the hip. Again, causes pain and swelling. Doesn't heal itself. So, when you have pain from arthritis or cartilage injury, What's the common denominator? Well, it's pain. It may come and go, may come at certain times, certain activities, may occur at rest. There's really kind of not one specific thing, but the basic is it doesn't get better. And that's because underlying it all is it can't heal itself. So if you strain a muscle, sprain an ankle, those things kind of gradually get better, give it a few weeks. Cartilage injury is kind of like having a flat tire or tread off that tire gradually wearing. It sits out there, it may not be a problem, but it doesn't get any better. And the more you drive on the tire, it tends to get a little worse over time. And that's kind of the hallmark of cartilage injury. It bothered me once, and now it's just kind of getting worse and worse over time. So if you have that type of problem, that, at some point it bothers you enough, you come in and see me. We're going to do a history and physical, evaluate you. 90% of the time after that, we have a pretty good diagnosis. But then we're going to get X-rays. And the main reason an orthopedist gets X-rays is the same reason that a cardiologist gets an EKG. It really gives them an insight to how your body's functioning. So here's an X-rays of a knee. I'm just going to tell you, this looks like a pretty normal knee on the left. There's the femur bone. You can obviously see the kneecap overlying it. There's the tibia bone. It looks like a space in between. There's a couple notches there, but that's where ligaments attach. That's normal. But that space is not a space. That cartilage cap that covers the end of the femur and the top of the tibia bone are there, and they're actually touching each other through those caps. But the cartilage doesn't show up on X-ray, neither the meniscus or the covering cartilage. So it looks like a space. That looks pretty normal. Now come over here and look at the opposite side. Where's the space go? It's gone. So it's easy for even you to diagnose that that cartilage is gone. Well, what does that mean? He has arthritis. Well, what's another way of saying that? He's got bone-on-bone arthritis. So that's a pretty easy diagnosis, at least for that. Now, a couple things. First off, there's no correlation between the amount of pain you have and what your X-ray looks like. So my partner, back in my group, has bone-on-bone arthritis. It's not quite that bad. He still runs half marathons once in a while. Well, because there really isn't correlation between their pain and what you find. So if you don't hurt, you don't have to fix it. The only reason you're coming to see me is generally you hurt and you're not able to do the things. That's when we want to treat you. But until then, it's not problematic to let you do what you want to do. The other thing about this X-ray is just because this person doesn't have anything on an X-ray doesn't mean they don't hurt. And they actually may hurt as much as this person, because we really don't know what the cartilage looks like. We kind of think it looks normal, but there may be other studies we need to do to reassure ourselves that it is. What's a hip look like? Well, when you look at a hip, it's a ball and a socket joint, all right? There's a space. That space is where the cartilage is. These two areas are touching each other through that cartilage cap. That hip looks normal to me. Okay, I can't see the cartilage, so I can't say 100%, but it looks normal. Now look over here at this hip. There's the socket, there's the top of the bone. Boy, there's no space in there. That's what an arthritic hip can look like. Those things right there are just little cysts within the head. Those are signs of arthritis. There's whiteness, which we call sclerosis. That's signs of arthritis. Okay, so I would imagine that this person hurts a lot more than this person, but they may not, so we'll do further things if necessary. And what are other further things we might do? Blood tests, or like look for gout and things like that that might hurt, joint fluid analysis. MRIs are pretty common. Now, I oftentimes think there's probably too many MRIs done. Many times patients are sent to me with an MRI they never needed because an X-ray would have shown me what I needed to know. But sometimes the MRI is needed. We don't see anything on X-ray. You still hurt, you're still swollen. Well, let's go get one, because the MRI, we can actually see the cartilage. We don't automatically get that test because honestly it's overkill and it's very expensive, and sometimes you just don't need it. But when it's needed, we do it. So once we've kind of made a diagnosis of a cartilage injury, well, what are the options? Well, there's all the conservative non-surgical options out there. We can think of medications and injections, and then we got other surgical options. While I'm a surgeon, I usually always ask the patient, has anybody done anything for you yet? Because I always would like to start at the top of the list. So my mom, who has an arthritic knee, we started there a long time ago. And we've kind of gone through this for the last 3 years, and now she's edging down here at the bottom of the list. And there's no harm in doing that, starting off slow and going further. There's also no harm in kind of jumping a few of these if you're really hurting or there's reasons to jump some. But for completeness sake, what are medications that can use? Well, you can use the most common one, which is Tylenol. It's a great medication. It can work. The trouble with it doesn't work a lot for cartilage injury because it's not very strong, and honestly, it doesn't reduce that inflammation component. So some people can get by on Tylenol, but many don't. Then there's the non-steroidals. The most basic one is aspirin, but Aleve, Motrin, Advil, Celebrex that I might write for you, or Mobic, all of those are very chemically similar and do the same things. Why do they work? Is because they reduce inflammation. They reduce that through the cascade of prostaglandins in your body. They reduce that. That's how they work. The trouble with them is they don't fix the problem. They don't fix the cartilage anyway. And the other problem is they affect the good prostaglandins too. So the prostaglandins in your stomach that help coat it and make it non-irritated, they can irritate your stomach. They can also affect the ones that are in your kidneys. So long-term, high blood pressure is not an uncommon problem with people who take these for a long period of time. So a lot of times your people coming in, their primary carers have taken them away. They're like, sorry, you can't use them anymore. So you're kind of stuck. It's not like I can give them to you and not affect your blood pressure. Then there's steroids. You can get steroids in pill form or more commonly injected into the joint. They're very, very strong, anti-inflammatory. Okay, so here's the handgun and here's the cannon, so to speak. They can really reduce the inflammation and last quite a while. The trouble with steroids is they do affect you systemically if you take them by mouth. So if you take them for a long period of time, it has bad effects on your body. If you inject them in the joint, especially over and over and over or too soon, it can actually soften the bone. So sometimes you can't use these forever and ever, but they're not a bad thing to do once in a while or once every 3, 4, 5 months, okay? But they don't fix the problem either, so eventually you still got the problem you came in with. Physical therapy. I put this slide up there. You don't need to go see a therapist per se to work out. What I mean by physical therapy is keeping up your strength of your muscles and keeping up your flexibility in your knee or your hip are very important. Anybody in this room could do a workout of their muscles and of their knee range of motion and be better off for it, me included. All right? But if you have arthritis, the number one thing is don't lose your flexibility. Don't stop moving your hip or your knee and just leave them still and come into me months later with this really stiff knee or hip. That's really hard to treat. So keeping flexible is very important. Now, does that translate into your cartilage getting better, or can you do an exercise that's going to make your cartilage better? No. So ultimately, you can grease the axle of the car and you can improve the steering function, but it isn't going to change the flat tire that you got on the back of the car. Joint fluid supplements, you can think of those being maybe rooster cone injections or joint juice injections. People know them by various names. Cox cone injections, because they're actually made from the comb of a rooster. What they basically are is they're a substance that mimics your joint fluid. They work by hydrating the cartilage cells that you still have left and theoretically plumping them up. It also theoretically improves the viscosity in your joint, and that in turn turns into better joint function. At least that's what the people that produce them say. My experience with the joint fluid injections is they kind of work some of the time. If you're bone on bone, they don't work. If you have some cartilage left, sometimes they work. And if you don't want surgery, they're certainly an option. But ultimately, they're not a long-term cure. Contrary to the pamphlet you might see even in my office or online or a friend, it's not like you're going to grow cartilage or plant seeds by getting these joint injections. So, if those are the kind of conservative things, what are surgical things that can be done? The first one's arthroscopy. I bring this up because this is the simplest one, okay? It's simple because it's very minor surgery. Make a couple small incisions on the knee. The surgery lasts maybe 15 or 20 minutes. Why arthroscopy is beneficial is you can do certain things inside the joint through those small incisions. So here's a picture here of, let's say, a knee where you're doing a scope, but you can do scopes of the hip as well. You can put a camera in one side, you can put tools in the other, and what you can do is you can look inside the joint everywhere, and you can do things like ligament reconstructions, or here, this is the end of the femur bone. There's the nice smooth cartilage. It's very smooth. There's the top of the tibia bone, the very nice smooth cartilage. There's the meniscus. There's a tear. That tear is irritating that joint. You can clip that tear out just like a hangnail. So via a scope, you can do smaller procedures, get away with it, and improve the patient's function and condition. And also, they very rapidly can get back to their normal activities. So, I mean, you even hear of NBA players having something minor done and coming back that season to play. Okay, so scopes can help. And in certain arthritic people, they can help a little bit. But unfortunately, they can't cure everything. So again, here's kind of what a normal distal femur looks like. Here's kind of a normal top of the tibia bone or cartilage. There's a meniscus. Here's a picture inside the scope. That's a little hook there that we're using as a tool. Well, look at that cartilage. It's like a big pothole in the middle of the bone. And what's that peeking through? Well, that's the bone right there, peeking through. So what do we call that? Well, that's basically kind of bone-on-bone arthritis. Via a scope, I can shave those things and smooth that around. And you know, that would, you would think, boy, that would make that better, wouldn't it? And it does. So if you get rid of that irritation in the joint, those flaps, it makes it better. But it doesn't change the fact there's going to be a big hole in that cartilage. All right, so ultimately, with a scope, I might be able to improve this patient's symptoms, but down the road, they're going to be back because there's a hole in that cartilage. And there's no way for me with a scope to put cartilage back on the joint. Okay, so a person with this type of problem, or who through that X-ray earlier had bone-on-bone arthritis, well, what's their option? Well, you can do a joint replacement. And a joint replacement procedure is basically where you're going in and removing damaged tissue or cartilage and you're replacing it with metal and plastic, a replacement for that. Now, before I go any further, and this is kind of an old site. I think this site is maybe even in 2000. There's more than 500,000 knee replacements done a year in the US and more than 500,000 hip replacements done in the US a year. Why? Because they work and they do well. Did you know that actually 80 or 90% of those replacements are done by surgeons that do less than 100 a year? Because there's a lot of surgeons out there. Less than 100 a year. You know, I did 600 some last year. There's facilities that do maybe 100, 200, 300 a year, and there's facilities that do 2,000 or 3,000 a year. I bring that up, and it is a little self-serving, but honestly, orthopedics especially is highly specialized. Okay? So there's people that specialize in certain areas, and hospitals that specialize. And there's been several studies that show that patients that go to a specialist or go to a special hospital do better overall. What's the simple answer? Practice makes perfect, honestly. All right? If you do things over and over again, you tend to get good at it. Nobody's great at doing everything. So if I do every surgery, I'm not good at any one of them. If I do something over and over, I actually get better at doing it. Plus, people that specialize tend to be up on the current literature and using the most recent stuff. It's easier for me to do that than to a person that's doing a bunch of different stuff to keep up with whatever's occurring. Okay? And hospitals are the same. Hospitals that do a lot of surgeries a year have protocols set up that really reduce your infection rate, which is very important to you, but also tend to get you out of the hospital sooner. They tend to have a higher rating by patients because their pain is controlled better. And I put this out to you. I mean, I don't know if you all know, you have the #1 joint replacement hospital in the entire state in this town. Over there in the OERU campus, Oklahoma Surgical. It's the #1 in the state. It's been that way for 3 years. It's in the top 30 in the nation out of, I think, 3,000 hospitals. Okay? And recently, I think there was this little article in the paper I read this Sunday. It's the only joint replacement hospital that got 5 stars by Medicare patients. They actually went out, it's the first, they're moving to this quality-based payment system. So through the Obamacare, they're going to pay hospitals based on quality and not quantity. So they're ranking things. Well, the first ranking that came out is really based on patient satisfaction rankings. And it's the only 5-star one in the entire town. I won't name the other ones, but most of them are 2 stars in the town. So, I mean, there is a big difference. And so when you're going out and searching for that, that's something to think about when you're thinking about getting your joint replaced. Whether it's you here in town or it's your loved one in Denver, you know, and you're like, where should I go in Denver? Well, you look for the hospital that does a lot. And you talk to the patient who goes to the guy who does a lot of them, and you find out, and you ask them, you know, do you like that guy? How well did you do? And you find out. So that's important for you to look at. So in joint replacement, what are the goals? Relieve pain and restore motion. That's not your goal, that's my goal. Your goal is to relieve pain and let me do what I want to do. I want to walk my dog, I want to go golfing, I want to hunt again or whatever. You're basically relieving pain to get function back. Well, how do we do that? Well, let's go back to what we thought about the basics about your hip joint. And again, simplicity. How can I explain what I'm going to do is going to help you? Well, think about it. The hip joint's made of 2 bones, ligaments, tendons, muscles, cartilage. The big problem here is not the bone problem, it's a cartilage problem. That cartilage is worn out at the top. So what are we going to do? We're going to replace that cartilage. How are we going to replace it? What we're basically going to do is we're going to go down and make an incision around the hip. We're going to go around the muscles. There's not going to be cutting of muscle and taking tendons off. We're going to go around. We're going to go back down. And what we're going to do is we're going to remove that cartilage. How we're going to do it? We're going to take the top ball off the joint. By removing that ball, we're able to put a stem down into your natural canal. And the reason we put that stem is so we can put a new ball on top. On the opposite side, we put a cup inside your natural cup. Then we're able to put that plastic liner I talked about earlier inside that. Here's the ball coming off. There's the socket going in with a plastic liner. That's the new cartilage surface. There's the stem going into the bone and a new ball on top. Now that's a little simplistic of a video because the muscles and tendons stay the same. So you basically get a new ball and socket joint, all right? So here we are beforehand. That's a normal hip. Here's a bad hip. Cartilage is bad. Here's the replaced hip. There's the top part of the stem with the ball. There's the socket in your socket, and there's the liner. So you're getting a new ball and socket joint. We're not replacing the whole thing, but we're replacing the ball and the cartilage portion. Here's a little bit of, here's what it looks like on an X-ray. So you can see the stem going into the canal. We put that there so we can put a ball on it. We put a socket inside your socket so that we can put a liner in there. So it basically gives you a new ball socket joint. We want this to function as normal as possible. I'm not going to make you a marathon runner if you haven't been a marathon runner. But if you used to be able to hunt and you can't hunt anymore because your hips are arthritic, we're going to do a replacement to get rid of that pain and then try to rehab you. You can go back pheasant hunting again if you want to, or fishing or whatever it is. Or if you just want to be able to walk downstairs without pain, like my mom, we're going to do a replacement to try to get you to be able to do that. All right, so that's a hip. What about a knee? Again, the knee is made up of 3 bones, muscles, tendons, stuff like that. What's the problem in a knee? The problem is a cartilage problem. It's worn out, it's torn. The arthroscopy is not going to work. How are we going to replace that cartilage? We're going to replace it with a metal cap. Okay, we're going to get rid of that cartilage and put a mimic of cartilage on top. It's just going to be metal and plastic. We're going to leave all your muscles, tendons, ligament attachments the same way they are, but cover the bone with a cap of metal and cartilage. So there's the knee. We stripped all the muscles and everything away. The problem is the joint and the cartilage. So we're going to take that cartilage layer off. It's about 8 millimeters thick or 9. Then we're going to put a cap of metal that's 8 or 9 millimeters thick on top. Same with the tibia bone. Take that cartilage off, about 8 or 9 millimeters, and put a cap back on it, 8 or 9 millimeters, giving you a new surface. Okay, that's a knee replacement. So we're not going to chop the bone out, take the knee out, put a knee in. We're going to resurface the bone. So here it is again. That's your normal cartilage. There's the bad stuff. There's the metal. Looks pretty similar. It's covering the end of the bone. Here's an X-ray. There's the cover. There's the cover. Just like your cartilage, you can't see the cartilage here because it's a plastic. But there's, you can kind of see the liner there from the side. This is the front. This is the side view. There's your kneecap. Everybody goes, did you take my kneecap out? I don't know why everybody asks that. Everybody asks, did you take my kneecap out? And I'm like, I don't know, whoever said that we ever took a kneecap out. But the kneecap's still there, but it's resurfaced. So it's got a new surface on the back side, just like the other joints do, so it makes it smooth again. Now, I'm not going to promise you 80 years, or 60 years, or even 50 years, or let you, what you did before, because we can't make as good a cartilage as what you were born with, but it's very, very good. In fact, the engineering behind it has improved dramatically. So someone asked earlier about, what wears away, or, the plastics. We talk about that plastic piece, in the 60s when they first came out with these, there was a couple sizes of joints and there was one piece of plastic, and boy, that plastic probably didn't last super long, but it was better than what you had. And then time progressed, 80s and 90s, and people got talked to about 5 or 10 years of wearing out. Well, now they have these plastics that if you run them in a lab over and over and over again, I mean, they may last 20 or 30 years, okay? So we talk about doing implants like these in younger and younger patients. I mean, I'm not gonna do a replacement if it's not gonna help you, but if you can't do the things you wanna do, I gotta work, I'm a mail carrier, I'm a sheriff, I'm somebody which I've taken care of, and I need to be able to walk. Okay, I'm 45, I still need to do things. Well, you know what? We're going to replace your knee and try to get you back doing the things you want to do. The recovery usually is a couple days in the hospital. It's 4 to 6 weeks of hard work. We're not going to let you sit around. You're an athlete. This isn't plastic surgery. We're not going to put you in a spa and put cucumbers on your eyes and let you lay there. You're in orthopedics. We're going to make you work out. We're going to get a therapist on you, and we're going to work out daily to maximize your recovery and make you better than you were before, like Steve Austin, the $6 million man. Better than you were before. Better, stronger, faster, so to speak. It will take a couple months in general to kind of rehab yourself, but the goal being you come out afterwards and going, I'm a lot better person than I was. I can feel better. I feel better. I may not have cured all my ills, but my knee or hip are better. That translates into me doing better. Limitations. I got this slide from Stryker, and these are limitations in the sense that I don't love people to do these high contact loading, jumping, running, jogging, but I also have patients that do every one of these, honestly. So if you're a good skier, I let you go skiing. If you want to play basketball at Thanksgiving with your kids, I don't have a problem. I wouldn't do it every day. But the reason we can allow people to do that is we're better at doing it, and the implants are better. So they are going to last longer and longer. Now, is there a skier out there that would have had a 30-year knee that is now skeeted away to a 15-year knee? I guess that's possible. But was that 15 years of skiing a good 15 years of living that they wouldn't have had otherwise? We're here once. At least most of us believe that we're here once. I mean, do you want to live your life the way you want to live it? You want to be able to do things you want to do. So that's what we try to help you do. So, joint replacements, I just told you, are a fantastic thing. Boy, they're done well. They feel good. We can get you back doing what you want to do, so we're done. There shouldn't really be anything else, should there? Well, what if there is something else? Okay, let's think about your knee, and if you have arthritis and it's isolated to one area of your joint. Do you really have to remove all the cartilage and replace all the cartilage? What if you could replace just a portion of that cartilage with metal and plastic? A partial joint replacement. What would the advantage of that? Well, the advantage, maybe you could do it through a smaller incision, so the recovery would be more rapid, and because you kept more of the joint, you'd actually feel more normal. So there's some advantage to do that. But you know what? Partial joint replacements actually exist. I did one, I don't know, just a couple weeks ago. This X-ray, unfortunately, is flipped, but this is the worn out portion. The rest of the joint looked good. So we replaced just that portion of the joint, okay? Partial joint replacements have actually been around almost as long as full joint replacements. You go, well, and why haven't I heard about partial joint replacements more? That's because we don't do them. Why is that? Because they're really hard to do. Technically, they're very difficult, even for guys like me to do. And what's that translate into? That translates into, I don't do as good a job. Well, the patient doesn't really like their knee as much. And boy, that knee doesn't last as long. Why would that be? And I tried to figure out how to explain it to you, and the best way I know how is a knee replacement, why it functions well is we're replacing the cartilage, but why does it also function as well is what we're doing is balancing the ligaments during surgery. We're balancing so the knee moves normally for you as well. It's kind of like balancing the tires on the car. The reason you balance your tires is so the car dries normally and smoothly so that the tires wear evenly. And it's kind of like that in a knee replacement. You want both sides, the inside and outside, to balance so the knee moves smooth and tracks smoothly both. And in a joint replacement, you kind of have access to the whole joint. It's all open up for you. In a partial replacement, you only have access to either the inside or the outside. You don't have information about the other side. So imagine, if you will, balancing your tires, both of them, but you only have access to one wheel. If you're really good at it, you have a good idea what the other side's doing. You can kind of balance them, but some of the times you're kind of like, well, that isn't quite as good a balance as I would have liked, okay? So that's like partial replacements. You can't balance as well. So in the past, partial replacements didn't do as well because they didn't always get the results you wanted and they didn't last as long. But then a couple years ago, some new technology come out that I adapted that really has improved the safety and accuracy. And basically, you may have all heard of it, called MAKOplasty. It's robotic arm assisted surgery. The basis for it is basically if you come in, you have arthritis, it's isolated to an area, you're a good candidate. Well, the first thing we're going to do is we're going to get a 3D model built of your knee. We're going to get a scan done. And we're going to basically take that scan and put it in a computer, and we're going to make a model of your knee, a virtual model of your knee. And you're going to go home. And you're going to wait for your surgery, but we're going to remain active. What we're going to do is we're going to take that 3D model and I'm going to put it on a computer program, and where this cartilage is worn out, we're going to take these virtual implants and we're going to fit them to your bone from the bottom, the side, and the back. And we're going to make sure that implant fits it the exact way we want to mimic the cartilage. We're going to do that on the femur bone, and we're going to do that on the tibia bone, okay? We're going to make sure it fits perfectly. This is before you've even come in. During surgery, it's the actual important part, the balance. We're going to, when you're asleep and during surgery, we're going to put your knee through a range of motion and balance that ligament. And I'm going to get that information about that opposite side by balancing you. Feed that into the computer. And then what I'm going to do is I'm going to adjust those virtual implants by clicking up, down, back, side, front, or by 0.5 millimeter increments until we get an exact fit, which is what we had before surgery, but also a balance of your ligament tension throughout surgery or throughout range of motion. Okay? We've done all that. We still haven't even removed any tissue from you. We've kind of have the idea of how the whole surgery is going to go, but we haven't really done it yet. And there's the final product of what we think is going to happen. That's the plan. It's over here. And then I'm going to have the guy bring over this giant Zamboni machine of a robotic arm. Looks like those old sweepers that the janitors use that walk behind. It looks like a Zamboni in hockey. They move it over and they set it on the ground, and there's this big arm that comes out, and out at the end of that big arm, there's this tiny little dental burr. So all that big machine is just so we can take that little tiny dental burr and we can introduce it into your knee. And through that robotic arm and through that plan, we essentially remove the tissue that I've planned to remove to fit the implants exactly like the plan. And it accurately works every time. The reason being is if I try to force that arm away from that plan, the system shuts down. It won't do it. It has to meet the plan I wanted. And honestly, you know, it is a little bit of leap of faith the first couple times I did it, but it comes out exactly like the plan every time. You get this kind of perfect balance. So not only do you get a replacement, but you get the balance you want, which is more what is important to the patient. You get sculpted bone to customize the implant to you. So here's a little diagram, basically the dental burn. It really is a dental burn. What you're basically doing is removing the tissue, and that's what we see up on the top right when we're doing it. The green is the tissue we want to remove. Here's the femur side, removing the cartilage tissue we want to remove or whatever's left diseased. On this particular video, they do the kneecap as well, but that's not very common. And what you'll see is after we remove that cartilage or diseased tissue, we just take the robot away, and then we insert the implant. That's the implant for the bad cartilage on that side. There's the implant for the other side. Fits on the end. And they'll show you the one for the kneecap as well. All right, now this isn't a Terminator. He doesn't walk in the room and do the surgery. I'm like, Terminator, do surgery, and they come in and do it, and I sit there. I'm doing it. It's my plan. I'm adjusting it during surgery, but it's with a level of accuracy that I can't mimic. Now you'd say, well, should we be doing that for full replacements? Well, at this point, there's not really a need for it, per se. The precision that you do is almost just, it's probably just as accurate as me doing it as having that robot do it or assist in it, okay? But someday, yeah, the robot may be assist as well. Here's afterwards. So your kneecap is actually right in there. You can't see it because it's turned over. There's the incision. It's probably about that big. There's the implant on the end of the femur and the top of the tibia. Here's a little, this is just a little thing we put in that we can mark that basically identifies you during the surgery. We do have to put 2 small trackers in the femur and the tibia during surgery because we basically use kind of GPS coordination to do it. It's beaming back information about the location of your knee and the cartilage. All right? Partial replacements, so they're functional. They do very well. They're not for everybody, but they're for a lot of people. You don't know until you come in. I would not have a partial done for me unless it was robotic assisted, and that's an honest answer to you. That's just because I don't think they do as well. But you know what? I also wouldn't try to convince you to get a partial if a knee replacement, a full replacement is what you want, because you can get a great result from a full replacement too. So it's a limited number of people that actually benefit from that partial. Now everybody would benefit from this, painless joint replacement. Wouldn't that be great? There's no such thing. All right, you're gonna have some pain. But you know what? It's a lot better than it used to be.